Hello, everyone, and a warm welcome to today's edition of Podcast. Today is Tuesday, June 6th, 2023, but it is already June 7th in Australia, where our speaker is today. She is in Sydney, Dr. Catriona McKenzie. So I'm Rifat Mannan in California, and I am remotely joined by my good friend Emilio Madrigal in Boston. So we are very delighted today to welcome back Dr. Catriona McKenzie, who has delivered talks before on our platform. And we all know that she is a staff pathologist at Royal Prince Alfred Hospital, Sydney. So today she is going to give a talk on a very common entity in dermatopathology, that is basal cell carcinomas. And the title of her talk will be Reporting Basal Cell Carcinomas, WHO 5th edition 2023 classification, structured reporting, and practical tips. And Dr. McKenzie will be using menti.com as she did the last time. It was very popular. And you just have to log into menti.com and use that code that you can see on the screen. And you will be able to interact with her on the questions that she is going to post during her talk. Thank you, Dr. McKenzie, for joining us today. Over to you now.
A pleasure, and thank you for having me again. I'm just going to switch off my camera and we'll switch that back on at the end. So yes, if you can log into menti.com and put this code in, you're able to join the lecture as I give it and take place in the polling. So as Rifat said, I'm lecturing today on basal cell carcinomas, including the WHO 5th edition and aspects of structured reporting and practical tips from Australia, which is a sunburnt country. And I'm from Sydney, which is situated here down on the East Coast. So just to get the ball rolling and to check that the polling's working, I'm wondering, what do you think is the estimated annual expenditure on keratinocyte carcinomas in the States? So your choices here are $1 billion, $3 billion, $5 billion, and $7 billion. Hopefully you can... So I'll just give it another few seconds. Hopefully we'll see some more polls. Okay, I'll proceed. It would be great if anyone live can join in and poll. So that the correct answer is the annual cost is towards $5 billion in the States. And in Australia, expenditure on keratinocyte tumours, which includes SCCs and BCCs, is close to 10% of the cancer budget. BCCs are the most common malignant tumours in humans and represent 80% of all tumours. And Australia has the perhaps not proud, record for the highest incidence of basal cell carcinomas in the world. The incidence is rising. This is inversely proportional to latitude, and the rising incidence is thought to relate to increased travel, aging population, and probably increased detection as well. And you can see in this Australian data that their incidence dwarfs all other solid tumours combined. So I was fortunate to take part in this study known as the OnTrack study, which was published in the New England Journal of Medicine a few years ago, which looked at nicotinamide, which is vitamin B3, as for skin cancer chemo prevention. And I'm not really going to talk so much about the study today, but the work that came out of it in basal cell carcinomas. We've also had a follow-up study published again in the New England Journal on using this agent in skin cancer, in transplant recipients who, as you know, have a very high incidence of skin cancers. So my role as a pathologist in the study was to classify all of the keratinocyte carcinomas, including the basal cell carcinoma subtypes, of which there were several hundred. And our sort of, findings from the literature and a subsequent article we published have led to modifications of the WHO classification. So when we looked through the literature at classifying BCCs, we found over the years 66 subtypes have been described in the literature with relatively poor inter-observer variability. And the definitions of the high-risk subtypes in particular were quite precise when we went to set criteria for classifying these in our studies. So we did publish our findings as an editorial with some more precise definitions for high-risk subtypes, and suggested, implementation of a two-tiered classification based on risk of recurrence, which has been adopted by WHO in 2018 and in the most recent version of the Blue Book. So again, to start this conversation, how would you classify this basal cell carcinoma? I'll give you all a minute to respond. So your choices are nodular, micronodular, mixed, nodular and micronodular, infundibulocystic, or BCC with adnexal differentiation. So I'll give a second more. So that's interesting. I think this is in fact a nodular basal cell carcinoma, and I'll talk more about it as we go through the lecture when we talk about the subtypes. But I think, this polling, is demonstrating, the considerable inter-observer variability and probably imprecise definitions that this field has. So why is it even important that we identify these subtypes? Essentially, it's pivotal to subsequent clinical management. So in Australia and most international guidelines, wide excision margins are recommended for high-risk basal cell carcinoma subtypes. So misclassification can potentially lead to, unnecessary surgery. And these particular high-risk subtypes, the micronodular, morphic and infiltrating, have a higher incidence of positive tumour margins, perineural invasion, local recurrence, and metastases, although this is very rare. And also importantly, are unlikely to respond to some of the non-surgical therapies such as topical imiquimod or photodynamic therapy. So the WHO classification of BCCs, as I said, we reviewed the classification to 2018, and it's currently, the 5th edition is currently available in beta revision, as a beta edition on the website. So if you have a subscription to the WHO website, you can look now, and everything I'm going to be presenting is available online. So the BCCs are broadly divided into two groups according to their risk of recurrence. So the low-risk subtypes include superficial, nodular, including the pigmented and keratotic subtypes, infundibulocystic, or BCC with adnexal differentiation, and fibroepithelial BCC. And the high-risk group includes micronodular, infiltrating, sclerosing, basosquamous, and BCC with sarcomatoid differentiation. So I will start going through these now in a systematic fashion. So just another poll, how would you classify this BCC? So your choices are superficial multifocal, fibroepithelial, or nodular. And again, please don't be shy. So good stuff. I think we're obviously seeing most people, think it's either superficial or superficial multifocal, and I'll come to the terminology in just a second. So superficial BCC is defined as a type of BCC, often with multifocal epidermal connection that is confined to the papillary dermis. The essential criteria in WHO, and this new version, this current edition of the WHO book follows the sort of systematic outline that's used for all tumours. They're trying to make it all uniform. So our essential criteria include this erythematous scaly patches on dermoscopy, and then histology shows these lobules of basaloid cells with peripheral palisading extending into the papillary dermis. Not uncommonly, you see retraction of lobules from the surrounding fibromyxoid stroma, and you may see this lymphoplasmacytic infiltrate. And not uncommonly, you see them admixed with regions of nodular, micronodular, or infiltrating basal cell carcinoma. The term multifocal has been taken out, although you do still see it used from time to time. And this was based on a study which actually reconstructed basal cell carcinomas. So although we see them as multifocal, in one plane on a slide, when they reconstructed them, they actually showed that they're all one tumour, and all these little lobules we see projecting into the dermis do connect up using serial sections and reconstruction. There are a few, controversies when it came to terminology or for a definition of these. It's not really clear whether these represent an in situ or an invasive carcinoma. And the exact definition has also been subject to some controversy. Most agree it's less than 1 millimetre, although narrower sort of depths are suggested by some, although there is general agreement that they should not extend beyond the papillary dermis. Which brings me to the question whether we should measure depth on these, which I know is not standard in many practices. But, there is some evidence that the thickness or depth of the basal cell carcinoma will determine their response to some of these topical treatments. And our dermatologists like us to give a depth for all of these. I think something else to be aware of is if you just see a bit of this sort of stromal reaction, increased vascularity, fibrosis, inflammation in a lesion that's seen as a BCC, it is worth doing levels. And this is just an example here where you have maybe a suggestion of an early superficial BCC, which becomes very obvious as you cut into the tumour. There aren't too many differential diagnoses for these, but occasionally we see cases where it can be a little tricky to differentiate from a proliferative sort of actinic keratosis. And I find Burr EP4 can be helpful to differentiate from an actinic keratosis in these cases. So moving now to nodular basal cell carcinoma, which is the most common type of BCC you see, which is defined by these well-circumscribed large dermal tumour islands with peripheral palisading. Essential criteria include a pink papular nodule. They're quite commonly ulcerated and may be pigmented. And then under the microscope, I'm sure you're all very familiar with this appearance of these well-circumscribed variably sized nodules with peripheral palisading, some retraction, typically connected with the epidermis. You may see some apoptosis in the centre of the nodules. The surrounding stroma is generally quite paucicellular, and you can get some amyloid or colloidal type collagen stroma, but shouldn't see desmoplasia. So again, I guess moving to perhaps one of the controversial areas, how would you classify this basal cell carcinoma? So just nodular basosquamous carcinoma. I think you can hopefully appreciate, the bit of squamous differentiation in this lesion. keratinizing basal cell carcinoma, or BCC with squamous differentiation. And again, it's great seeing this, the I guess spectrum of responses here in the live polling, with a spread of responses in these tumours, seen with nodular being the most popular choice. So under the current WHO classification, they've included keratinizing BCC as a variant of nodular basal cell carcinoma. In practice, I find we very commonly see some, bland squamous differentiation in these. And I personally often don't even mention it, just because of the potential confusion with basosquamous carcinoma, which I'll talk about it with the higher risk lesions, which can lead, I guess, sort of be a bit misleading for the treating doctors. The other variants, these are just histological variants, include, the nodular cystic variant, adenoid BCC, clear cell, signet green, granular, and the giant or monster cell type. So these are all, regarded as variants of nodular basal cell carcinoma. The pigmented basal cell carcinoma is also regarded as a variant of nodular BCC, which is more common in Asian, African, and Hispanic populations. So this was separated out as a separate, being classified as an individual entity in the 2018 WHO, basically because clinically it can look quite worrying and has a broad differential, but the decision has been made now to include it as a variant of basal cell carcinoma. Beware that, rarely you can get colonization of basal cell carcinomas by melanoma, particularly the lentigo maligna subtype. Both of these lesions, of course, being very common in sun-damaged skin. And this is just a higher power view showing pigment within dendritic cells can also occur within the actual tumour cells. Differential diagnoses include micronodular and basosquamous carcinoma, which I'll talk about with the higher risk basal cell carcinomas, adenoid cystic carcinoma, and Merkel cell carcinoma. I think sometimes nodular BCCs, particularly when they're a bit ulcerated, may look a bit hyperchromatic and might make you consider Merkel cell carcinoma in the diagnosis. In Merkel cell carcinoma, CK20 is very helpful, which will show perinuclear dots, typical sort of staining pattern. But something to be aware of is that neuroendocrine differentiation is actually quite common in basal cell carcinomas, with synaptophysin and chromogranin expression described in up to nearly 30% of cases in some studies. I know it's not a marker you'd normally order on these, but just good to be aware if you're considering Merkel carcinoma in the differential, and the CK20 will be very useful in this case. So the other lower risk subtypes that were recognised in WHO include infundibulocystic BCC, which is regarded as a variant of BCC with follicular, sebaceous, or apocrine differentiation. Interestingly, they didn't put a picture of this in, and I didn't have one in my files to show. And then the other variant is the fibroepithelial BCC, which I quite liked the old name actually, the fibroepithelioma of Pincus. Which, again, it's quite controversial as to whether this is a variant of basal cell carcinoma or represents some sort of adnexal tumour. Clinically present as an exophytic or flesh-coloured nodule, and you see this quite characteristic appearance of these strands of basaloid epithelium with peripheral palisading with a surrounding fibroblastic stroma. So moving now to the higher risk subtypes recognised by WHO. These include micronodular, infiltrating, sclerosing or morphaic BCC, basosquamous carcinoma, and BCC with sarcomatoid differentiation. So when we did the on-track study, we found the micronodular BCC was probably the most, inconsistently diagnosed, and I would say overdiagnosed. I think in its, pure form, it's actually, I think genuine examples are actually quite rare. And it's certainly not a diagnosis I think you should be making on a regular basis. So as I said, it's an aggressive type of basal cell carcinoma characterized by these small nests with an irregular tentacular or infiltrative deep or peripheral edge, and it typically extends deeply into the dermis or beyond. So looking at essential criteria, it really should have this infiltrative, permeative growth pattern being comprised primarily of small nests and ideally extending into the deep dermis or, further. And I'd be quite, cautious in making the diagnosis if the lesion's confined to the papillary dermis. So as I said, you see these rounded ovoid cells often going quite deeply through the skin. And as a guide, this should be the predominant pattern in the tumour, with these rounded, small, discrete groups of cells. Again, like other basal cell carcinomas, it's often mixed with other patterns, including nodular and infiltrative basal cell carcinoma. You can see, and you need to be quite careful when you report these, you can see single nodules, a long way from the bulk of the main tumour. They can reach quite a large size and may demonstrate perineural involvement. As you can see in this case, you do need to look quite carefully for this. This is just another example here where you can see nodules of, or micronodules going down into quite deep into the reticular dermis. They can sometimes, I've noticed, go quite a long way sort of laterally as well. And this is just another example here where you can see the nodules going deep into the dermis subcutis and actually into underlying muscle in this example, can be quite subtle. The main differential diagnosis is with a nodular basal cell carcinoma. So to distinguish the two, I think focal micronodular architecture is seen in nodular BCC, but nodular BCC is encased by a common stroma and lacks that satellite or sort of, infiltrative pattern seen in micronodular BCC. Punch biopsies, which I'll talk a little bit more about in a minute, have a significant false negative rate for detecting micronodular BCC and other mixed tumours. And I think, there's quite a, varied reports in the literature, about their prognosis. And I think, misoriented sections and the lack of strict definitions in terms of the size and number of micronodules has probably contributed to a poor intra-observer reproducibility of these tumours. So again, these are examples of what, we would call nodular basal cell carcinomas, although, they do have small nodules within them. And the thing that I think differentiates them from micronodular BCC is this encasement by a common stroma and the lack of this infiltrative or permeative growth pattern. And I think important in punch biopsies to consider doing deeper levels. So this is the case I showed you near the beginning, which, some people call nodular or mixed, micronodular or mixed nodular micronodular BCC. But you can see on levels, in fact, all of these nodules actually grow, join up, and the tumour is actually quite well circumscribed and encased by this common stroma. So I would call this a nodular basal cell carcinoma. And I think, tangential sectioning of some of these little lobular projections and can give rise to an erroneous impression of micronodular BCC. So infiltrating basal cell carcinoma is characterized by elongated islands and strands of basaloid cells that are quite, again, poorly circumscribed with these sort of spiking projections, and they can look a bit like a scar clinically. So these are essential criteria, which includes these variably sized, sometimes jagged nest of basaloid tumour cells infiltrating dermal collagen. Again, with this, irregular permeating pattern at the deep edge of the tumour, and perineural invasion may be present. So about 1/3 are mixed with a nodular basal cell carcinoma, and they often overlap with sclerosing or morphaic BCC and micronodular BCCs. And there are some arguments which I think are quite valid, and I'll talk a bit about this when I talk more about the reporting, to group these three together as infiltrating BCC. So this is just a couple of other examples from our files. So you can see in this case, you've got really deep invasion. This one's actually going right through the subcutis into underlying fascia, and perineural invasion is common. And I always look, carefully in these more aggressive basal cell carcinomas for perineural invasion. Just another example here, which is maybe a bit less cellular than the previous examples. But if you look, you can see these jagged little nests going quite deeply. I think, moving now, to sort of traps, I guess, in the diagnosis of infiltrating basal cell carcinoma. So in the on-track study, had the opportunity with a number of cases to review both the punch biopsies and subsequent excisions. And I think a common trap is that in ulcerated nodular basal cell carcinomas, you get this sort of, or traumatized basal cell carcinomas, you get this sort of pseudo-infiltrating appearance. So this was called an infiltrating basal cell carcinoma on punch biopsy. But you can see in the subsequent wide excision, it's a fairly classic nodular basal cell carcinoma. So I think we do need to be wary in punch biopsies, particularly if you see, this evident either ulceration or evidence of surface irritation. And this is just another example here of an ulcerated nodular basal cell carcinoma, where you get this pseudo-infiltrative sort of appearance. And again, looking in the literature, this is where a high discordance between punch biopsies and subsequent excisions is well described. So I think it is something, we do need to be aware of, and perhaps, consider levels or be a little circumspect in your report if you're not sure what subtype it is. Moving now to sclerosing or morphaic BCC. And again, I think this terminology is being used, inconsistency in the literature, with some people using this term for what I've described as a infiltrating basal cell carcinoma. So this term's confined to basal cell carcinomas that are surrounded by this abundant collagenous stroma. And again, they can have this sort of scar-like, quite subtle scar-like appearance clinically. So again, essential criteria include this scar-like plaque with narrow cords of tumour cells compressed by sclerotic or collagenous stroma. Again, like the other higher risk subtypes, perineural invasion is commonly present. So like the other high-risk subtypes, you really want to see this irregular, tentacular, deeply infiltrative border. These tends to have these quite narrow cords of cells compressed by this induced collagenous stroma. Palisading retraction is uncommon compared to those lower risk subtypes, and often overlaps, as I said, with infiltrating BCC, which definitionally lacks the prominent induced collagenous stroma. And this is just a higher power view from a case I had in my files with this really quite dense colloidal type collagen. And another example here. This is not a keloid scar, they hadn't been previous biopsy, but you can see this really quite incredible dense collagenous stroma in the sclerosing variant. So moving now to basosquamous carcinoma. So this type of carcinoma is defined as a BCC with areas of both basal cell carcinoma and squamous cell carcinoma, which may contain transition zones between the two. I think it's an area that's had very it's a bit confusing in the literature. So it's not recommended that the terms metatypical basal cell carcinoma or basal cell carcinoma with squamous differentiation are not recommended. I guess, as I said, because these, you often see some squamous differentiation in nodular BCCs, which is, quite bland and confers no risk. So I think that's, important to be aware of. Clinically, often there are slowly growing papule or nodule, often ulcerated, and we see basal cell carcinoma intermixed with squamous cell carcinoma. Under the desirable criteria, BER-EP4 immunohistochemistry is helpful to demonstrate the transitional zone or demonstration of partial staining of tumour with both basaloid and squamous morphology. So as I said, the pathogenesis of this tumour has been controversial over the years, with some thinking it represents a collision between BCC and squamous cell carcinoma. But the decision to include it as a variant of basal cell carcinoma is based on some molecular studies which show that it's a BCC that's undergone transformation to a higher grade squamous cell carcinoma. And the immunohistochemistry and histology back this up with, demonstration of a transition zone between a BER-EP4 positive EMA negative BCC component and a BER-EP4 negative EMA positive SCC component, as I said, supports their origin as a basal, or their origin from basal cell carcinoma. So these are really quite uncommon. And as I said, you have histologically and immunophenotypically distinct zones of BCC and SCC with transition between the two. Perineural invasion is common in these lesions. And this is an example of a case we had. So I'm sure many of you who see skins have noticed that the cartilage often sort of, I guess, acts as a barrier for carcinomas. But, this tumour has gone straight through the cartilage of the ear. And you can see this mixture of, basaloid component with peripheral palisading, with some areas of squamous differentiation, which in areas resemble a squamous cell carcinoma, shown on higher power here. So again, in stark contrast to the nodular BCC with some, bit of keratinization in it, the basosquamous cell carcinoma is an aggressive infiltrating tumour. And this is the immunohistochemistry on this case, demonstrating strong positive staining for BER-EP4 in the BCC component, and a sort of kind of mirror image is the right word, or it's kind of like a negative with the squamous cell carcinoma staining strongly with EMA. As I said, these are aggressive tumours, and they actually have a higher local recurrence rate than either BCC or SCC, and a high, which has been as high as 50% in some cases. The risk factors for recurrence include male gender, positive margins, lymphatic and perineural invasion. The metastatic rate is similar to a squamous cell carcinoma. The prognosis lies, once the patients have metastatic disease, the prognosis lies somewhere between a BCC, metastatic BCC, which is very rare, as you know, and an SCC. I think one of the main differential diagnosis is a poorly differentiated squamous cell carcinoma. And again, to, I guess, avoid confusion of terminology, I don't use the term basaloid squamous cell carcinoma because I think it is confusing, and it's not used in WHO either. So this is an example of a poorly differentiated squamous cell carcinoma that has this quite hyperchromatic look. although it doesn't really have convincing palisading, I don't think, with some areas of squamous differentiation seen within the tumour. And just in contrast to that previous case, the Burr EP4 is completely negative, and EMA was strongly positive throughout the tumour. So finally, BCC with sarcomatoid differentiation, this is very rare, defined as having an epithelial BCC component and malignant stroma that can differentiate towards a number of sarcomas, or resembling a number of other sarcomas. Terms metaplastic carcinoma, carcinosarcomatous BCC, sarcomatoid BCC, not recommended. So BCC with sarcomatoid differentiation is the current preferred term. So these generally are quite aggressive and present as rapidly growing new lesions or rapid enlargement of a longer standing lesion. And you see nodules of sort of fairly classic looking BCC separated by this malignant stroma, which ideally lacks staining for epithelial markers. This is really rare. I haven't actually seen a good example myself. This is from a case report in the AJSP, but you see nodules of BCC separated by this malignant mesenchymal stroma, which, as I said, can differentiate towards a number of entities. And the sarcomatous stroma will typically have focal or absent staining for keratins or P63. And again, at the molecular level, they've found, one of the common mutations of BCCs, both in the epithelial and sarcomatoid portions of the tumour, supporting their, inclusion as a basal cell carcinoma. So moving now for the final part of my talk on some common reporting issues in basal cell carcinomas, and some comments about structured reporting. So firstly, I guess there's controversy about how we classify these. I don't think there's any argument that 66 subtypes is not sustainable or a good idea. But there's been some, suggestions whether they should be just diagnosed into two groups as low risk or high risk. This wasn't adopted by the WHO and isn't supported by, treating doctors, as currently different treatment strategies are deployed for superficial and nodular basal cell carcinoma. And there's also evidence at the genetic level, these are separate entities as well supporting this. There's no difference in most treatment guidelines for infiltrative micronodular and morphaic BCC. So I think there, is some evidence for grouping these together. But to date, as I said, in spite of how common these tumours are and the huge cost to the health system, there've been fairly limited intra-observer variability studies to date. So in this study from 2014, 6 dermatopathologists looked at 100 BCCs, and they found very poor intra-observer disagreement when individual subtypes were used. And when pathologists were left to their own devices, they ended up with 17 subtypes. But when they grouped them or simplified it to a two-tiered rank of low and high risk groups, they did show much better intra-observer variability. The Europeans currently have also done an intra-observer study and looked at the WHO criteria, and they also supported unifying the infiltrating, sclerosing and micronodular BCCs into one group to improve reproducibility and, being quite a pragmatic approach as well, but kept the superficial nodular subtypes as separate. And then recently, this article's currently in press, but we also did a or intra-observer reproducibility study on basal cell carcinomas. We ended up looking at just over 90 tumours. We found we had substantial agreement for the superficial subtype, moderate agreement for the nodular, sclerosing and infiltrating subtypes. But again, when we divided it into a simplified two-tiered rank, we showed, quite substantial inter-observer agreement. So I think, there's certainly evidence to support a simplified approach, but we still, I think, need to do some work on, improving our consistency in classifying these incredibly common tumours. And as I said, at the genetic level, there is, evidence for separating out superficial nodular, and they've again, just demonstrating the sort of varied use of terminology, morpheoform, by which they meant those sort of higher risk infiltrating sort of basal cell carcinomas, with these three groups showing distinct gene profiles. And this is another more recent Japanese study, again showing some differences between the superficial and infiltrative variants of basal cell carcinoma. The British data set, and I think this is a very nice data set for reference, has adopted this fairly simplified approach into either low risk or high risk subtypes, and have grouped these three subtypes into infiltrative and separated out basosquamous carcinoma. I rarely diagnose fibroepithelial BCC. I think they might be quite uncommon. So another question I've talked to a few Australian audiences is how should we report mixed types? This is very common. At the moment, really, there's not much in the way of specific data on when a certain percentage or location of a subtype is biologically significant. And I adopt a fairly pragmatic approach along the lines of the British data set, whereby if a high risk component is present, you don't really need to record the low risk components. But I guess individual practice varies, but the important thing really is to correctly diagnose that high risk component in terms of ongoing management for patients. Now, finally, I realise this is quite a controversial area. As I said, incredibly common and expensive tumours. Should we be looking at using structured reporting for basal cell carcinomas? So at the moment, there's no ICCR structured report for these, and AJCC staging is only available for head and neck SCCs and BCCs. But to consider, the subtype is just one of the risk factors for recurrence of basal cell carcinoma. Other factors include size, stage, presence of perineural invasion, anatomic site, as well as some patient and factors such as history of multiple cancers and treatment-related factors as well. So in Australia, we have decided to initiate structured reporting for these tumours. So this is actually, if anybody wants to look it up, this is available on our college website as a public document, which you are all most welcome to look up and read through, because there's obviously too much detail to present in a 1-hour lecture. As I said, there's a lot of, this is a controversial area, and we got a lot of, let's say, enthusiastic feedback about this, concerns about, increased time taking to report these. So at the moment, we've got guidelines for the head and neck tumours and recommendations for keratinocyte tumours in other parts of the body. So in brief, because it's too much detail to go through in a shorter lecture, but this is the protocol for head and neck non-melanoma skin cancers. With our regional node dissections, we also have additional appendix for when lymph node dissection is present, which includes mandatory standards and guidelines. And at this point, we've recommended adoption of this for the high-risk BCC subtypes. So this includes, demographic information, handling all of these specimens in a very, consistent fashion, including differential inking of the specimen. And then these, as I said, these are the standards here and the guidelines on the right, but we think that, the subtype, grade, WHO risk category, depth, the anatomic extent of invasion, LVI, satellitosis, perineural invasion, margin status, and if received, lymph node status need to be recorded for these lesions, and for the head and neck tumours, the staging. For tumours arising at sites other than the head and neck, and as I said, that due to feedback, superficial BCCs are not currently included in this. Again, we have some guidelines for what clinical parameters should ideally be included, including orienting sutures, the specimen dimensions, and again, just systematic recording of blocks, inking, etc. Looking at the parameters included in the histology report, for BCCs, we recommend, so this is for non-superficial subtypes, we recommend inclusion of the histological subtype, WHO risk category, thickness and depth. At the moment, that there just aren't good studies showing which is more, appropriate. The anatomic extent of invasion, perineural invasion, LVI generally not relevant for BCCs other than perhaps the Basosquamous variant, and the status of the margins. And while this potentially sounds quite onerous, I actually find in practice it's very quick to do, particularly with voice recognition software and a pre-populated template. I quickly put, all this information in, including margin status, because I think until we, classify these consistently and collect all this data, we, really aren't, optimizing, patient care to, determine which parameters are important, and optimal treatment strategies as well for these tumours. To finish up, I think no pathology lectures complete without a mention of artificial intelligence. Can the robots do it better? And again, there are a number of studies coming through showing that the robots are quite good at picking basal cell carcinomas from normal skin and histological mimics. Again, obviously, there's a lot of work to be done here, particularly given the data from the inter-observer reproducibility studies, and how do we train the robots if we're not really good at doing some of this as humans? And I guess other parameters like perineural invasion and margins also need to be considered as well. So to summarize, BCCs are the world's most common tumour and cost billions of dollars around the world. I think we need to consistently classify these for more robust studies, including prognostic data. I'd support or recommend division into the low and high risk variants, and the classification that's in the recent WHO books. And I also would advocate the use of structured reporting, at a minimum for the high risk head and neck basal cell carcinomas. But, ideally, I think we need to look as a pathology community at reporting all basal cell carcinomas more systematically for better data collection and optimal patient care. And just, I guess, a reminder to be cautious on partial biopsy specimens because of the problems I outlined in diagnosing or, misinterpreting or misinterpretation on punch biopsy or partial biopsy specimens. So just finally, like to thank the members of my department of pathology at Prince Alfred Hospital in Sydney, and also particularly Professor Diona Damien, who was the dermatologist driving the New England Journal papers, and also my colleague Richard Scollier, who was the pathologist, who's very well regarded, well-known dermatopathologist who was involved in a lot of this work as well.
Thank you so much. Thanks a lot, Dr. McKenzie, for this very comprehensive discussion on basal cell carcinoma, its histologic variants, WHO reporting, and how we should probably report WHO, incorporating WHO classification into the reporting of basal cell carcinomas. Thanks so much, Dr. McKenzie. There are a few questions that I can see online. One question is, I can read it for you. If you have a tumor that is 90% squamous cell carcinoma and 10% BCC, we call it Basosquamous and say that it's a variant of BCC. But the prognosis is more like squamous cell carcinoma. And the comment from our colleague is, I think there is a good argument that they should be rather called variants of squamous cell carcinoma than variants of basal cell carcinoma. So you have any comments on that?
Yeah, look, I agree. It's a controversial and difficult area, but the molecular studies suggest that they do, in fact, originate from basal cell carcinoma, which was behind the rationale for including them in this group. But certainly take your point, and this has been a controversial area over the years.
Right. Thank you. Here is another question from one of our viewers is, why do we not see metastasis from basal cell carcinomas?
Good question. And I don't know why. And, it's, again, it's surprising when you look in the literature how, I think basal cell, there's an opportunity for some people here. They are an understudied tumor, I think, relative to their, frequency. But for whatever reason, they don't seem to have a propensity for vascular invasion. I don't have a, I don't know the explanation for that. It's interesting that the basosquamous cell carcinomas have a higher risk for metastasis, and that's perhaps pertaining to, their squamous component, I would think.
Thank you. So there is another question which is about immunohistochemistry for diagnosis of basal cell carcinoma. Is it necessary at all, or do you use it, or what's your comment on that?
So basically, no, not routinely. The only times I occasionally do it, as I think I showed you a photo of, it can be tricky sometimes to differentiate from an actinic keratosis when you've got a sort of bit of basaloid proliferation, and I find it quite useful there. So I do it occasionally. And then I guess the other situation I use it is in the basosquamous carcinomas to differentiate clear basaloid differentiation, or like that example of that poorly differentiated SCC that looks a bit basaloid. I think, very before an EMA can be quite handy to help distinguish those two entities. So no, certainly not part of my routine practice, just occasionally use those stains in those settings.
Yeah, thank you. So there is another question about measuring the size of the tumor and the depth of the tumor. So the size is where the question is about when you measure the depth, where do you start the measurement? Is it
so again, it's really interesting that there's not concordance in the literature for such a common tumor, but we've adopted in the Australian Synoptic Report a similar method to Breslow thickness. So from the granular layer to the base of the tumor, thickness and depth, I think we use them a bit interchangeably, but, thickness really is, I guess, more appropriate for a, more sort of exophytic tumour. But, that measures from the very top of the lesion to the bottom, whereas, the other method is akin to Breslow thickness for melanoma. So I must say the terminology does, it's a bit tricky because we're sort of calling it a depth, but using Breslow thickness, and I acknowledge the, difficulty of that. But basically, I measure it as a Breslow thickness in my ones. And as I said, in our synoptic report, there was pushback against, measuring superficial BCCs, but, our dermatologists do like it because, it can determine how well they respond to some of the topical treatments.
Right. Thank you. Here is another question. So, is it necessary to report the subtypes in intraoperative study? I mean, the frozen section or basal cell carcinoma?
So we don't do frozen sections on our basal cell carcinomas. So I guess I find it hard to answer that, but I guess probably should do best to, actually, that's not quite true. We occasionally get frozens from the head and neck when they're trying to decide how far to go. So yeah, I do try to give the subtype. If it's obviously superficial, I think that has, different connotations to if you're seeing infiltrating BCC on margin assessment. I had a series of frozens recently where they just kept, this tumour went forever and we kept seeing more and more superficial component. And in the end, they decided they would use topical treatment to treat that. So I think, liaising with the surgeons, but I would, attempt to differentiate them, or I do attempt to differentiate them when I do frozens. Although, as I said, the frozens aren't a routine part of our practice.
Right. Thank you. This is another question. I believe you might have mentioned about it, that what's the relationship with the histologic subtypes and the prognosis for the different basal cell carcinoma subtypes?
That's a good question. So, nodular basal cell carcinomas generally have, low risk of recurrence. It's, again, a lot of this stuff's quite controversial because superficial basal cell carcinomas are a low risk, sort of a lower risk tumour. They're not particularly aggressive, but can be quite extensive. So, I think that's why we need to also look at margins and other risk factors. And then the higher risk subtypes, or the more aggressive variants with work, that are more likely to recur, are the infiltrating, micronodular, sclerosing, basosquamous subtypes. But as I said, I think the subtype is just one part of the picture, and it's why we need to also consider or we need to include margins and those other, risk factors for local recurrence in our report to determine optimal subsequent management.
Right. This is more of a comment from one of our viewers who says that in Ireland and UK, they don't measure total thickness, but they measure the depth from adjacent granular cell layer.
The measured depth from granular cell layer. Yeah, I think that's fine. I think that's, yeah.
Right.
Yeah.
Right.
And I think in practice, I find then, I guess maybe the squamous cell carcinomas are more commonly exophytic. So I think that, Breslow thickness style granular cell layer to bottom is sufficient or adequate for most cases. I think that's good practice.
Right. This is a question about differential diagnosis. So how do you have a differential of adnexal tumors when you, what are the subtypes that would be in the differential diagnosis of adnexal tumors of the skin? That's one question.
Yeah, look, between you and maybe a few other thousand viewers, my question is usually, why is this not a basal cell carcinoma? They are so common in Australia. I have to find, and I must say, I think, adnexal tumours, I don't know who's mission those classifications, but there's so many and very difficult. So basically, if my question is, why isn't a basal cell carcinoma? If I call it one of the adnexal tumours, it really has to look, one of the benign adnexal tumours, it really has to look extraordinarily bland. I don't want to be seeing any mitoses, don't want to be seeing any of those, aggressive growth patterns. And if I see, those sort of, apoptosis, mitoses, I call it a basal cell carcinoma. So I know that doesn't really answer the question directly, but, basically I think, difficult and just have to be very cautious and make sure it isn't actually a basal cell carcinoma, because they are by far and away the more common lesion.
Right. Yeah, actually, another viewer has added the differential that does micronodular variant be, sometimes confused with adnexal tumors like trichoepithelioma or trichoblastoma? What's your
potentially. And I think that's why, if you just, you really do want to see that discohesive, to call it micronodular BCC, you really want to see those, discohesive nodules. I'd be quite skeptical of the diagnosis if it's, confined to the papillary dermis. I think to call it micronodular BCC, you really do want to see that infiltrating, sort of permeating pattern. And I think the genuine examples, go very, very deeply with those discrete, separate micronodules that differentiates it from some of those adnexal tumours, which tend to be, more superficial, often confined to the papillary dermis, or perhaps, superficial reticular dermis. So that's my approach.
Right. No, thank you. This is another related question, I think. So keratinizing BCC, you mentioned that it should be considered as a variant of nodular basal cell carcinoma. Is that correct?
That's correct, yeah. So that's the WHO approach. It's considered just a variant of nodular BCC. And personally, in practice, if I just see a little bit of squamous differentiation, I don't mention it at all. Again, just because, the surgeons or dermatologists sometimes, can misinterpret that as representing basosquamous cell carcinoma, which I think is a really very different, aggressive entity. So the WHO has just considered it a variant of, nodular BCC. And I think this is, correct. And again, quite pragmatic approach. So, I tend to just call them nodular, respect or, recognize that practice varies, but I just call these nodular basal cell carcinoma, and then use the term basosquamous carcinoma for those tumours with, an aggressive growth pattern and both actual squamous cell carcinoma, not just keratinization, and basal cell carcinoma in them.
Right. I think this question is also very similar. Do you have an IAC panel, or what is your IAC panel for differentiating BCC and trichoepithelioma?
I don't have one, I have to admit. I mainly use morphology. I don't know what the WHO book recommends.
Right. Okay. Mm-hmm. Let me see. I think these are all the questions, Dr. McKenzie, that I could find online. So did you want to add something about that?
No, not really. Thank you all for joining in and listening in today. I hope it's been useful. And I think as pathologists, this is our job to classify things, isn't it? And report them as reliably and accurately as possible. So I hope this is helpful for creating more consistency in this extraordinarily common tumour.
Right. No, this has been really very helpful, Dr. McKenzie, and I'm sure our viewers have enjoyed it and that they found it beneficial. And you would be surprised pleasantly, though, that we had over a couple of hundred viewers who joined from so many different parts of the world. And special shout out to one of our viewers who joined from Ireland and said that it is 1:30 a.m. there.
Oh, wow, that's key.
A huge shout out to you, and thanks for your support. And I hope you found it useful. And we also had a lot of other viewers who joined from Malaysia, Australia, UAE, Mexico, Puerto Rico, Taiwan, South Sudan, Brazil, Colombia, USA as well. And thanks to our viewers for your support to all of our lectures. And don't forget to subscribe to our YouTube channel, where you can find all the lectures according to a playlist. So you will be able to see Dr. McKenzie's previous lectures on liver pathology as well. And you can also follow our Facebook page. So that is by the same name, that is Podcast. And our next lecture is coming up, that is in 2 weeks from now. So we will have a GI pathology talk, and our speaker will be Dr. Raul Gonzalez, who would be giving a talk on pancreatobiliary intraductal lesions. And that is on June 20th. 9 a.m. Pacific time, 12 p.m. Eastern time. So hope to see you then. And thank you again, Dr. McKenzie, for this great talk on basal cell carcinomas. Thanks so much.
Pleasure, and thanks for putting this series together. I think it's a great thing for pathology.
Thank you. Thanks a lot.
Thank you.